So we'll have next Dr. Kiran speaking on MYOPIC CNVM.
Good afternoon and thank you for this opportunity. My topic is MYOPIC CNVM. Anjana gave a very good introduction to this topic. MYOPIC CNVM is the second most common cause of CNV after age-related macular degeneration. It is seen in 5.2 to 11.3% of pathological myopia, though it can be seen in any degree of myopia and without typical myopic degenerative fundus changes. The mean age of presentation was 56.1 in multicenter study called Radiance, but in Indian population it was seen a bit more lower age, 47.9. And coming to the natural history, initially it presents as a subretinal heme without subretinal fluid. And then in the second stage, the heme resolves, leaving and fibrosis happens, and there will be some variable amount of pigmentation, which is called fuchs spot. Then the CNV regresses, leading on to a area of chorioretinal atrophy. In a study done with a 10-year follow-up without any treatment, this myopic CNVM can lead to a vision deterioration to 20/200 or worse in 96% of the people. And 35% with myopic CNV in one eye can develop CNV in the fellow eye. So we need to keep a close watch on the other eye too. Mechanical theory is already being dealt with. AP anteposterior elongation leads to breaks in the RP Brooks choriocapillaries, which can lead to CNVM. And also choroidal filling delay can lead to choroidal ischemia, which can again lead to upregulation of angiogenic factors and then CNVM. There's also a genetic theory explained. The risk factors are high-grade myopic maculopathy, Lacos cracks, choroidal thinning, higher aqueous humor levels of inflammatory cytokines such as interleukin 6 and 8. The patient can present with decrease in vision, central scotoma, or it could be a very mild symptoms like a metamorphopsia. The most challenging part in the management of myopic CNVM is the detection part, because it can present with a very subtle changes like a small, the choroidal neovascular membrane could be very small with very minimal exudation and hemorrhages. It doesn't have a typical picture of an age-related macular degeneration. A type 2 CNV is the most common type seen. So we have to resort to the multimodal imaging to make a diagnosis and to follow up this patient. OCTA shows active lesions are seen as a primarily interlacing pattern, and in the inactive lesions have a tangled appearance. I will go through a few cases. This is one of such cases with the fundus. The patient had some metamorphopsia, not much drop in vision, and you could see a hyperreflective lesion above the RP with a single intraretinal fluid, and OCTA shows a small CNVM, and FFA shows leakage. So the FFA can be used to assess the activity of this neovascular membrane. A subtle leak on the FFA may be the only sign in these patients. There could be other pathologies coexisting, such as macular schisis. So in the left eye, you can see a neovascular membrane with a lot of cystic spaces and schitic area. So so one could use FFA to know the size, location of the lesion, and also to assess the activity of the CNVM. The differential diagnosis include macular hemorrhages from the Lacos cracks, dome-shaped maculopathy, inflammatory CNVM. So our main aim is to detect it early and treat before the fibrosis sets in. So early detection and early treatment is the key. Laser photocoagulation and PDT has been tried with the limited vision improvement. Anti-VEGF is the first line treatment. So this patient underwent 2 injections in 2020, and you can see the fuzzy borders of the hyperreflective material become well defined, and the resolution of the fluid, and OCTA also shows resolution of the membrane. But the presence of this flow signals in OCTA doesn't mean the disease is active. So we can use FFA to know for sure the CNVM is inactive, so that we can stop the treatment. This is the second patient who also had a resolution of the fluid, but the schisis is still persisting. So Radiance is a randomized control study done with ranibizumab in myopic CNVM. They found a mean improvement of 10 letters, and what striking was the mean injection needed was only 3.5, and they followed a strategy of one injection followed by PRN without any loading dosage. And in the study, from the month 6 to 12, more than 60% of the patients receiving ranibizumab did not receive any injections. And real world data also showed almost similar results. 52.2% needed only one injection, and nearly 90% needed only less than 3 injections during 12 months. Aflibercept also showed similar, almost similar results with mean injection of 4.2. Bevacizumab also found to be non-inferior to rasumab. So in short, this can be managed with a injection followed by a PRN regimen without a loading dosage. The factors affecting treatment outcomes include older age. The poor prognostic factors include older age, sub-4V location of CNV, large lesion size, poor presenting visual acuity, thinner choroid, and lac of cracks. The next problem that we expect is the recurrence, and in a two-year study, they found the recurrence to be 23.3%, and the majority of the recurrences occurred during the first year. In the post-radiance observation study also, the recurrence after 1 year was only 10%. So the most of the recurrences in the first year, and the main predictor for the recurrences, the number of injections needed to control the initial disease. If it is high, there is more chance of recurrence. The higher the baseline CNVM size, the more chance of recurrence. The additional injections needed to treat this recurrence were only 1.9, and the final visual acuity was also similar in both the cases who had recurrence and non-recurrence. So we can use a treatment regimen of one injection followed by PRN, stricter follow-up in the first year, and most of these studies have shown that the vision has persisted. Had the visual gains persisted for almost 3 to 5 years, but some patients started developing drop of vision after 5 years. The important reason found for this drop in vision is because of the choroidal atrophy that sets in beyond this stage. And in conclusion, usually younger age group are affected compared to the age-related macular degeneration. And the key point is they have very subtle changes, so you have to be very careful, especially in the background of other coexisting pathologies. It's very difficult to pick up these changes, so we have to resort to this multimodal imaging. And anti-VEGFs are found to be very efficacious, and the recurrence and the number needed were very low compared to a age-related macular degeneration. And closer follow-up in the first year, then you can relax the follow-up. Early detection and early treatment is the key for the treatment. And even in the patients with center scarring and with the eccentric CNVM, parafoveal CNVM, if they recur also, it's better to treat them because the patient requires only very few injections, and they can have a large scotoma if left untreated, because most of the size, the vision may be already be compromised. Thank you.
Thank you for the presentation. Can you answer a question for? Can you just explain the basic differences between myopic CNVM and AMD CNVM for the benefit of the audience, treatment and management wise?
First of all, they present with very subtle signs. The picking up part is the most difficult one. The number of injections needed are very less. It's almost half.
I think meanwhile Dirish can start his talk.
Compared to the CNVM secondary to the age-related thing, and most of them, the recurrence is also very low. So it is easier to treat. Most of the anti-VEGF work equally well. So there is no confusion between the choice. Just that they need to be started early and picked up early before the. And most of the studies, many people might be worried about the peripheral degenerative changes, whether the patient will go in for RD and etc. when you treat them. But most of the studies have not shown any, severe, complications such as RD in their studies. So it's really, anyone can be confident in injecting this patient, just that you need to screen them for any treatable lesions in the periphery.
That brings to a question, if you see a lattice and the myopic CNVM, will you treat the CNVM first or will you treat the lattice first?
I mean, if it is a break, I mean, if it's a lattice, alone pigmental lattice, I don't think it's a must to treat. But to be on the safer side, if you feel the patient is elderly, the PVD is happening or something, it's better to treat. Better to be safe than having a